My name is Auscultation Quiet and I'm the chairperson of the BROCA Society. Today, I've been requested to perform the CVS examination to help you, the viewers, with your OSCE preparation. This is our patient, Ms. Notila, and she's kindly offered to allow us to demonstrate this examination on her. As with any examination, we start off with professional communication and approach. Good evening, Ms. Notila. My name is Auscultation Quiet. I'm a third-year medical student. May I have your age, please?
32.
Pleasure to meet you, Ms. Notila, and your age. We now know your age as well. Ensure that the patient is comfortable as well. Ask the patient if they would like a chaperone. Would you like someone to be here with you during this examination, Ms. Notila?
No, I'm okay.
Okay, thank you so much. Then allow us to proceed with description of the setting and preparation. Always ensure that the patient is in a comfortable, private, well-lit environment. Ensure that the patient is well, the patient is properly exposed for this examination at a 45-degree angle. Ensure that the chest is exposed. For the purposes of privacy for this video, we will not expose the patient. Ensure that your hands have been warmed, washed and cleaned appropriately, and that you are wearing gloves if necessary. Ensure that you have the appropriate equipment. For this examination, it helps to have 2 rulers to assess the JVP. Ensure that you have a working stethoscope as well, which will be necessary for the auscultation stage. And ensure that you have a pen torch, which also aids with the identification of the JVP. Determine if the patient is showing any signs of respiratory distress, which would be indicated by nasal flaring, tachypnea, and use of the sternocleidomastoid muscles on respiration. The patient may also have cyanosis. Examine the patient's nutritional status. The patient may be wasted in cases of chronic congestive heart failure, which leads to cachexia. Make sure to note this. After proper inspection, we then start with examination of the vital signs. It is good to stand at the foot of the bed to assess the patient's respiratory rate. So what you do is you'd examine the rise and fall of the chest, how many breaths the patient, how many times the patient breathes within 15 seconds, and multiply this by 4. The normal breathing rate is 12 to 20 breaths per minute. We then proceed to examine the patient's radial pulse. You can examine it now, but we will also examine it during the specific CVS examination. So what you're going to do is feel for the radial pulse, lateral to the flexicarpi radialis tendon, feel it for about 30 seconds, and then multiply the number of beats you feel by 2, which will give you the rate in per minute. Normally, the radial pulse rate is 60 to 100 beats per minute, with an average of 72 beats per minute. Also, so we've stated its rate, also state its rhythm. Is it regular? Is it irregularly irregular? Or is it irregularly irregular? Also make sure to examine the patient's skin temperature with the back of your hand moving to the forehead. Also assess skin hydration, one of the other important vital signs. So pinch the skin lightly and allow it to snap back. If it snaps back quickly, it's an indication the patient has normal hydration. From here, I like to proceed to examine the fingers. So, first of all, examine the nails. Look for any pallor or cyanosis of the nails, which is not present in this patient. Push against the nail bed and the nail and examine for capillary refill. We see that the blood quickly returns to the nail bed and it turns a pink color very quickly, which is a sign of normal capillary refill. Proceed to examine the nails thereafter. Look for any signs of splinter hemorrhages, which should be caused by trauma, infective endocarditis, or vasculitis. Look for any staining of the fingers as well, and then proceed to examine for clubbing. So there are 3 tests for clubbing. First of all, assess for fluctuation of the nail bed. In clubbing, you'd feel hyperfluctuation of the nail bed. That is not present in this patient. Then examine the nail bed horizontally. Look for the angle between the nail bed and the skin tissue behind it. Normally there's an obtuse angle. In patients with clubbing, you'll find a reduction in this obtuse angle. Please may you do this for me, Ms. Notila, with both of your fingers. Thank you. This is the 3rd test for clubbing. This test allows us to visualize Shamrot's window. Look for the space between the nails. If this is present, it suggests that clubbing is not found in this patient. Thank you. Then what we're going to do is look at the palms, look for any signs of pallor again, look for any palmar erythema, Dupuytren's contracture, or any Janeway lesions. I should have also mentioned, since Janeway lesions are related to Osler's nodes in infective endocarditis, you would look for Osler's nodes along the fingers as well. We then move up the arm as well. You could assess the brachial pulse at this rate, but we'll leave that for the CVS examination. We move to the head. So first of all, look for the hairline and for any abnormalities of the hairline, such as a receding hairline. That is not present in this patient. Thereafter, examine the face. Look for general symmetry of the face and for any presence of any syndromic features, such as in patients with Down syndrome. Also look for mitral fasces, which would be indicated by rosy discoloration along the malar region, which would be present in patients with mitral stenosis. Thereafter, proceed to examine the eyes. So, what you're going to do is, may you look up for me, Ms. Notila, please. Thank you. What you're going to do is lower the eyelid, look for any sinus pallor. You can also look for conjunctivitis as well. Look down for me, please, Ms. Notila. We would look for any signs of jaundice. Look for arcus senilis as well around the eyes, which is a blue hazy discoloration, which would be found in elderly patients or in some patients with the lipid abnormalities. Thereafter, we move to the mouth. Look at the angles of the mouth for any angular cheilitis. Look for dry lips. Look for any dry lips. Yes. Can you open your mouth for me, Ms. Notila? Thank you. Say ah.
Ah.
So now what we're looking for is any signs of dental caries, any signs of gingivitis around the gums. Look for any essential cyanosis or pallor of the tongue. We can also look at the uvula. But remember, you would normally use a tongue depressor when examining the tongue. You can also look for any oral thrush as well. You say ah for me, please.
Ah.
Try to visualize the uvula as best as you can, and also the pharynx for any signs of pharyngitis. Thereafter, we can move on to assessing the lymph nodes. Please may you sit up for me, please, Ms. Notila, and just swing your legs over to that side of the bed. For a focused general examination involving the CVS, it's only necessary to assess the lymph nodes in the neck, feeling along the anterior triangle, feeling the supraclavicular lymph nodes. Can you turn your head to the left for me, please, Ms. Notila? And feeling for Virchow's node in the left supraclavicular fossa, which would be enlarged in Trozier sign. Thank you. So remember to use your right hand for the patient's left side and your left hand for the patient's right side. So just move your arm aside for me quickly, please. Try to relax, Mr. Notila. Feel for the axillary lymph nodes anteriorly, medially, apically, and posteriorly. Make sure that you do this in the other axilla as well to compare. And you can also assess for the epitrochlear lymph nodes as well. Thank you. Please may you lie down, Ms. Notila. Thank you. You then proceed to examine the legs. Look for any signs of calf tenderness and warmth. Then assess for pitting edema. Normally, as mentioned before, the patient will be properly exposed. Place your thumb along the anterior tibia and gently press against the skin for about 10 to 15 seconds. You would then release and see if there is any depression in the skin, which would be an indication of pedal edema. Also assess the toes at this stage for cyanosis, pallor, or clubbing. Remember to assess the brachial pulse for character and volume here in the antecubital fossa. Assess the carotid pulse as well. It would be between the two heads of the sternocleidomastoid muscle. Can you turn your head to the right for me, Mr. Notila? Try to feel for character and volume as well. You only need to mention these pulses: the femoral pulse, the popliteal pulse, and the dorsalis pedis pulse, if you can. Next, as part of inspection, we're going to assess JVP. When examining the JVP, it's important to have an effective light source on hand. What you're going to ask the patient to do is, so Mr. Notila, please can you turn your head to the left for me, please? Thank you. Now, what we're going to do is try to visualize the JVP. The way to distinguish the JVP from a carotid pulse is that the JVP has a triple waveform. It is not palpable, and it is easily occludable. Now, it may be difficult to visualize when filmed at this angle, but nonetheless, we will try to measure it as best as we can. So, to confirm that this is the JVP, what you can do is perform a hepatojugular reflux test. First, ask the patient if they feel any pain around the abdomen. Do you feel any pain around your abdomen, Ms. Notila?
No.
No. Thank you. So gently press against the abdomen and see if there's a sudden pulsation in the JVP. Yes, so we can see it around here. So what you do then is you try to ensure that you mark off the position where what you believe is the maximum height of the JVP. Then place you use two rulers. Place one at the sternal angle and align the other ruler horizontally until it reaches the height of the JVP. Now, in this patient, we can see that the vertical height along this ruler is about 1.5 centimeters. As long as it's below 2 centimeters, this is normal. Remember that the angle of the sternum is about 5 centimeters above the right atrium. So you would add your measurement to 5 centimeters, which would be 1.5 centimeters to 5 centimeters, and then compare that to the normal JVP height, which is about 7 centimeters. After we've completed the inspection section, we move on to palpation. So what you're going to do is try to feel for any tracheal deviation. Do you feel, it might be a bit uncomfortable when I put my fingers here, Ms. Nantila. I'll just try to feel for your trachea. Okay, thank you. Try to feel for any tracheal deviation. Thank you. Then what you do is you place your hand along the chest to try to feel for a palpable A2 or a palpable P2. Then you would try to localize the apex beat. Try to feel for the heartbeat and then localize its position. Start from the second intercostal space, move downwards. Normally, the apex beat would be in the fifth intercostal space in the midclavicular line. If you cannot feel the apex beat, then you try to turn the patient over to the left side. Ms. Nantila, thank you. This will throw the heart forward and allow you to try to feel for the apex beat. But after doing this maneuver, you can't comment on the position of the apex beat. Thank you. Return to your normal position. Ms. Nantila. You can also try to feel for any palpable thrills at this stage. Then we assess for parasternal heave. So what you do is you place the palm of the heel of your right hand against the chest and ask the patient to breathe in and out. The parasternal heave is not present in this patient. Then you can move on to percussion. Percussion is not essential for this examination, but you can use it to assess for cardiac dullness, especially if you suspect a cardiomegaly. This is the last step of the CVS specific examination and possibly one of the most important steps. What we're going to do is auscultation. We're going to listen for the heart sounds. So we're going to listen for the aortic valve in the patient's second intercostal space on the right side of the midline. You listen for the pulmonary valve in the second intercostal space on the patient's left side. You listen for the tricuspid valve in the fourth intercostal space on the patient's left side. And you listen for the mitral valve in the fifth intercostal space on the left side as well. So what you do is we start off with using the diaphragm. And what you do is we start in the mitral area. Make sure to comment on normal heart sounds, any murmurs, or any added heart sounds. Ask the patient to breathe in and out. Note that when listening for the mitral valve and the aortic valve, the sounds will be louder on expiration. Then move on to the tricuspid valve. Breathe in and out for me, please, Ms. Nantila. Again, making the necessary commentary. Listen for the breathe in and out again for me, please. Thank you. Again, listen for the pulmonary valve. And then the aortic valve. Thank you. May you turn to the left, please, Ms. Nantila. Now, normally at this stage of the auscultation, when listening for the mitral valve again, while the patient is turned to the left, you'd use the barrel of the stethoscope. This seems to be an older model though. Again, try to listen for the mitral valve. Thank you. Now please may you sit up for me, Ms. Natila. Please. Thank you so much. When the patient is sitting up, you would only listen in 3 areas: the tricuspid valve area, the pulmonary area, and the aortic area. So once again, we repeat this process. Breathe in and out for me, please, Ms. Natila. Thank you, Ms. Natila. While the patient is in this position, one can also test for sacral edema. Thank you. Please lie down, Ms. Natila. And this concludes the examination. Also, always remember to summarize your findings to the examiner. We find that after a focused general examination and a CVS examination of this patient, we have seen no abnormalities. Remember to thank and clothe your patient appropriately after the examination. Thank you kindly, Mr. Natila. Thank you. This is an Ashik Pramchand of BROCA. Better speakers, better don't.